complication may be. Got it. Okay. Sometimes it's important to press a little bit with the transducer on the abdomen in order to get a better image. And sometimes a good collaboration with the patient. So you invite the patient to inspire. And and other tips and tricks, which I will tell you, may be helpful for good pancreas evaluation. So these are the scanning plans. We start with the transverse, then you do interlongitudinal. For the head, you rotate a little bit the transducer to your left, and then a little bit up. For the tail, you rotate it to the right, your right, and a little bit downwards. And sometimes you need this kind of section. You invite the patient to lay on the decubitus, right lateral decubitus, and you will see better the patient. So this is the pancreas. You see here this organ is quite homogeneous. It has some surrounding structures that are very, very important. Please remember that the best surrounding structure to delineate and to detect the pancreas is the splenic vein, is this one. But also there are other structures around which are very important: the aorta, the superior mesenteric artery, or the inferior vena cava. And I will show you shortly also a video. You see the pancreas. This is the head. Okay, and then if you need to see the tail of the pancreas, you use that technique that I have. This is the head. Now you see the head, you see the body, and now the tail. Again, that image. And for the tail, you have also this kind of section through the spleen, which gives us a very good acoustic window, and you see the tail of the patient from that part. Of course, what I have told you in the beginning, a good anatomy, and you should be able to detect all the vascular structures that are around the pancreas: the hepatic artery, the common hepatic artery, the splenic artery, truncus celiacus, the veins, the superior mesenteric vein or superior mesenteric arteries, the duodenum, are very, very important to be able to delineate very well the pancreas. So in various sections, you should detect all these landmarks, and it's very important to know them by heart. So they may be also involved in some pathology, and that's why you should know them very, very, very well. So this is the section you see very well the tail. You see for example, in this section, the left renal vein, the left renal artery, and here through the spleen, you see also the splenic vein. So when you examine the patient, it's important to first of all to describe the echotexture of the pancreas, to describe the capsule and the pancreatic duct. The echogenicity should be reported in comparison to the echogenicity of the healthy liver. Of course, if the patient is a heavy drinker and has steatosis, then it's difficult to know, and you don't have a good comparison here in that case. And you should be able to see also the pancreatic duct is usually below 2 millimeters, but with a good technique, you are able to detect. I will show. The gland dimension measurements are not necessary in routine examination. So these are the sizes. So head 2.5 maximum size, body 1.4, 5, and the tail 3.5. These dimensions are slightly lower in elderly patients, but they are very important, for example, in patients with acute pancreatitis. There are limitations when you examine the patient. For example, in obesity, so patients with overweight, in that case, it's very difficult to see the patient. If the patients are uncooperant, when there are meteorismus, and here is the problem with acute pancreatitis, when usually the patient has a lot of gas into the abdomen, and it's very difficult in that case to see pancreas. After surgeries, to detect, for example, complications after surgery, ultrasound may be helpful, but here, due to abdominal scars, sometimes we are not so confident in what we see. Sometimes some parts are very difficult to be directly examined. There are some tips and tricks. We can fill the stomach with water, so we will create an acoustic window. You know that ultrasound waves are traveling very well through a liquid. So in that way, we eliminate the gas from the stomach. So the ultrasound waves will get through the stomach, and you will see very well the pancreas. Letting the patient stop breathing in any phase of the breathing circle. When you see the pancreas, then you say stop, and then you examine very well the patient. Changing the patient's position to standing or sitting, it depends, and using all kinds of oblique positions in order to get a very good image. This is what we have discovered during our work with a lot of patients. Blow up the belly, so the patient should press a little bit. And you see here, in the beginning, we were not able to see the pancreas, but we invite the patient to press the belly, and you see suddenly the pancreas appears. And I don't know. So we are able to see very well at the end the entire pancreas. So in the beginning, the pancreas were not correctly detected by ultrasound. Of course, don't forget the new techniques that all the ultrasound machines have nowadays, and contrast enhanced ultrasound is probably the most important of them, elastography also, and all these features you have on another kind of ultrasound examination, which is endoscopic ultrasound, which I'm sure you know that for pancreas is one of the best imaging methods in order to detect various changes. You see here, if you have high resolution probe, you are able to detect very well all the structures, all the capsule is very well seen, but you need higher frequencies to detect all these changes. You see here, the pancreatic duct, which is dilated here, is very well seen. We see here some echogenic spots in the pancreas. You see also the layer of the stomach wall. So if we have a good image, of course you cannot use this kind of image when the patient is with meteorism, but when the patient is normal, with normal weight, we can use it and see very well all the structure. Tissue harmonic imaging gives you the possibility to better delineate the contours of the organ and the vessel. Okay, so let's move to some pathology. What could be important for you when you start to examine the pancreas and to integrate ultrasound in your diagnosis management of the patient. So after history, physical examination, lab test, the next, you don't need here the stethoscope, but you may have an ultrasound probe. and you put the ultrasound probe in the epigastrium, and you try to see the pancreas and to detect some changes that could be helpful in the final diagnosis. So we will speak something about echogenicity of the pancreas in structures, Wilson duct changes, and we'll speak about solid pancreatic lesion and cystic pancreatic lesion. So here is a pancreas which has, you see, a little bit lobulated structure. This is common in children. The children have this kind of pancreas, but it's sometimes also possible to see in adults. Sometimes you see that the echogenicity of the pancreas is very high. The pancreas is very wide. In the beginning, was not considered something extraordinary, but nowadays this lipomatosis of the pancreas is considered to be a pathological change. So those patients are more prone to develop diabetes. So it's important that you note when you do an examination that the patient is very echogenic. Then the next step is to detect the Wilson duct. Here you see the Wilson duct usually lies in the middle of the pancreas. Here is the Wilson duct. It is not a normal one because you see that the walls are not regular, and it's in a Wilson duct in a patient with chronic pancreatitis. And here is a also dilated Wilson duct in a patient with a tumor. So always try to see the entire course of the Wilson duct or the pancreatic duct, because it may give you some information regarding the pathology. Regarding solid pancreatic lesion, you see here some lesions. This is the pancreas. You see here a hypoechoic lesion in the body and in the tail of the pancreas, which is not very well defined. You see here another small one. You see here another one. These are very similar. And here another hypoechoic structure into the pancreas. Only with this image, of course, you cannot see, you cannot guess what it is. You need more information. You need, first of all, the clinical picture of the patient. If the patient has lost a lot of weight, has abdominal pain radiating to the back, most probably this is a pancreatic cancer and adductor adenocarcinoma. If the patient, for example, is a young man without symptoms, maybe a neuroendocrine tumor. This was a small metastasis in a patient with melanoma. So you need definitely more information to have the final diagnosis. But for you, as a beginner, you should know all this, and you should decide which is the next examination to perform in order to have the final diagnosis. So, how can we differentiate solid pancreatic lesion? What we should look at? At ultrasound, the size, the contour, the echogenicity, the invasion. If you have high resolution ultrasound, you should look to some lesions, how is the aspect of them, to see the vessels with color Doppler. Use contrast enhanced ultrasound is very helpful because it gives you information about the lesion in terms of vascularity. Hyper, hypo, or iso, because we will see some lesions are hyper, some lesions are hypo. And elastography also gives to you an information regarding how hard is the hardness about the lesion. See some pancreatic lesion, you see a lesion hypoechoed in the head, you see the dilation of the Wilson duct, you see some irregular vessels, and the dilation of the common bile duct. What do you think? What kind of lesion could be in a patient with who lose a lot of weight? It's most probably ductal adenocarcinoma. Here we have scale, and not many vessels here, the same, and we do a contrast enhanced ultrasound in order to see the vascularity. Why? Because usually ductal adenocarcinoma are hypovascular. So you see that these lesions face less contrast than the surrounding pancreas. We should differentiate those tumoral lesions from pseudotumoral chronic pancreatitis, autoimmune pancreatitis, and large neuroendocrine tumors. You see here a pancreas, the head was enlarged. There is a little bit dilation of a common bile duct, but you see here you can note that the structure of the pancreas is not completely loose. It's not hypoechoic, and you see that Wilson duct is from that case. It's irregular in a patient who drinks a lot of alcohol, and it's clear a chronic pancreatitis. But another case, it was a mass. We thought that maybe it's a tumor, very vascularized, hard at when we did the elastography. Here the scale is blue means hard, red means soft. It was a hard one, but in contrast, we saw that the lesion was hypervascularized. And so it was against the pancreatic adenocarcinoma, and in fact, it was a chronic autoimmune pancreatitis in a patient affected by IgG4 disease. You see here, very hypervascular was the lesion. Another case, a lesion detected in the tail of the pancreas, and contrast enhanced ultrasound, we saw that the lesion was hypervascularized. So also against a normal ductal adenocarcinoma, it was a neuroendocrine tumor. So in that way, using the information from ultrasound, from contrast enhanced ultrasound and elastography, we're able to tell more about that lesion. Of course, I will want to emphasize that this is the first step. For all the pancreatic lesions, you need to do a very good staging. For that, you need CT, and you need sometimes a better characterization, and for that, you need better examining techniques than ultrasound. You need endoscopic ultrasound, and you need sometimes MRI or MRCT. Regarding cystic pancreatic lesions, we have pseudocysts. You will see that these kind of lesions appear in patients with pancreatitis, either acute or chronic. And we have non-pseudocysts. We have cystic pancreatic tumors like serous cystadenoma or mucinous cystadenoma. We will see some. You see here a lot of cystic lesions. Some of them have something inside, some of them are pure cystic. So, of course, you need a lot of other information. Probably this one, without other nodules inside, without septa, in a patient affected by acute pancreatitis, is a pseudocyst. But here we have a nodule inside in a patient with pain and weight loss. It probably is a tumor. So if you see something inside, then you should think of also. For the cystic lesions, we have this clinical imaging diagnosis, pseudocyst versus non-pseudocyst, cystic tumor versus tumor-like lesions, benign versus malignant. Sometimes it's very difficult. There are some lesions which are benign ones, the serous microcystic adenoma. I want to show you this kind of lesion because it's cystic, but are very small cysts, and because we have a lot of interfaces, the lesion looks like solid. So you don't not like this one, which is clearly with fluid. Is clearly that lesion occurs in patients with in elderly women. Multinucleus neoplasms, you see the difference. They are larger. We have septa inside, and a lot of septa which are thick. There may be uni or multilocular, and these are mucinous cystic neoplasms, and they are borderline or malignant and should be carefully investigated further. You see here lesions that already are malignant with very thick walls, with nodules inside, with high tumoral markers. So if you see this kind of lesion, solid liquid with a solid component into the cystic one is most clearly cystic adenocarcinoma. There are other lesions, the intraductary papillary incinus neoplasm, IPNM, which are not so rare now. There are a lot of lesions discovered now. They can be of main type. So if you see a large pancreatic duct and maybe a cystic lesion in the body or in the tail, this is the main duct. See here, and it's secreting mucus. If you do a endoscopy, you see mucus coming out from the papilla. This is the main duct, and sometimes you see the tumor. This is the branch duct, the side branch IPNM, and you see here something inside the cystic lesion, and also in that in the pancreatic duct. So look not only if the duct is enlarged, but also if something inside. It's not pure black like this. It is something inside, and mucus gives you this appearance. So these are the problems that you have to face as clinicians, because you should integrate the information obtained by ultrasound in your clinical judgment, and finally to have the final diagnosis. So luckily, you have other investigation in hand. You may perform SEWs to see if the lesion is vascularized or not. You have the possibility to do MRI, and you have the possibility to do US, endoscopic ultrasound plus FNA, to have the final diagnosis. Most of the cystic lesions are in fact pudous. Here, very important is the clinical context after acute pancreatitis, and you see those lesions quite common in GI department. So these are the features that you should look at when you judge such a case: the age, location of the lesion, history of if the patient has acute pancreatitis or chronic pancreatitis, size, the walls, septa, the thickness is important, projections, the Wilson duct, and of course you should move to other investigations. Regarding one of the good applications of ultrasound is in acute pancreatitis. If you are in a ward, a patient is coming to you with abdominal pain, and you suspect after important meal with alcohol, and you suspect that the patient has some acute pancreatitis. You see here, in that case, that the lesion is enlarged, that the pancreas is enlarged, hypoechoic. We have a little bit of fluid near the pancreas. So this is an acute pancreatitis. This was a lucky case when we are able to see all the pancreas, but usually due to gas, you cannot see all the pancreas. This was a edematous pancreatitis. If you have a necrotic pancreatitis, we may see necrosis either inside or outside the organ. You see here those very nice pictures with pancreas with a lot of lesions, which are not tumors, are necrosis. You have to demonstrate that, and you have at hand, you have contrasting hands ultrasound, and with contrasting hands ultrasound, I don't know what not moving in the end, we are able to demonstrate that that lesions are not vascularized. So that means that there is necrotic tissue. You see here necrosis, and this was a necrotic pancreatitis. Regarding chronic pancreatitis, that you know from if you did the gastroenterology, which are the pathological changes you will find in such a disease, and all these pathological changes may be seen with ultrasound. You should look at the contour, the structure, the presence of cysts, the Wilson duct dilation. Here is very, very important, this information. Always look at the Wilson duct and classifications. And we have major signs of chronic pancreatitis and minor signs. In our webinar, you will hear a presentation of a paper with which is dealing with this ultrasound diagnosis of chronic pancreatitis and how confident are we in diagnosis. Here's some pictures with chronic pancreatitis and enlarged head of the pancreas, a dilated Wilson duct. Here, this picture that you have seen with irregular course. Here, the same irregular course. If you see this kind of picture, you are almost sure that the patient has chronic pancreatitis. Always try to find if the patient does not have stones inside. Here, a tiny one. Here, a very large stone in a very dilated pancreatic duct. Of course, we have a lot of complications. Some of them may be detected with ultrasound, like stenosis or compressions on the surrounding structure. We have, if you working in a GI department, where we do endoscopic treatment of chronic pancreatitis, and you see that kind of image into the Wilson duct. This is a stent placed into the Wilson. This new technology helps us a lot, as I have told you. High resolution, contrast, and elastography. And this is a hard tissue here, and you see how well is defined by the strain elastography. We have also another shear wave elastography, which gives you exactly the hardness of that tissue. So to conclude, the examination of the pancreas is a challenge for the beginner. That's why you need careful and perseverant examination to be able to see and evaluate the patient in almost all cases. A correct evaluation of the pancreas must visualize all the segments and assess the echogenicity and echostructure of the entire organ. If you detect a focal or diffuse parenchymal changes, then you should use another technique in order to characterize the lesion. You may use other ultrasound techniques if you are experienced enough, or in most of the cases you need sectional imaging methods like CT, MRI, MRCT, or EUS to have the final diagnosis. Don't forget, you are students. You should do a very complete examination. So the history of the patient and the clinical data are of utmost importance. Don't forget to do this. And of course, you should know the diseases where ultrasound is important in the follow-up of the patient, like acute pancreatitis, in order to avoid a lot of CTs. Because you will irradiate the patient. When you follow up the patient, ultrasound is very good for acute pancreatitis, and also to follow up patients with cystic lesions, which are initially characterized as these. Okay, I thank you very much for that attention.
Thank you very much for your very nice and complete presentation. Thank you very much, Zeno. there was a question. I look again in our chat. There was a question by a colleague from Cameroon, and he asked, can we sometimes see two ducts? You spoke about that we have two kind of tumors of the pancreatic duct, but normally we see one. Sometimes we have also a small duct in the head. Can we sometimes see this part?
Yes, when the ventral and the dorsal part of the duct are not connected, then we may see two ducts which are not connected. And of course, this is a situation when the patient is in danger to have acute pancreatitis. But sometimes the ventral duct is very difficult to be detected with transabdominal ultrasound.
Yes, that's right. We have to use then the endoscopic ultrasound. There, the differentiation, the resolution is really better. And then we can see the Santorini, ductus Santorini, and on the other side, the Wirsunghianus, normally we can see from outside. Yes, okay. Are there in the auditorium, we go back, are there some other questions of the other in the chat? David, can you see a question in the chat? Please stop your presentation, then we can see the participants.
Sorry, what?
Stop it, yes, and we can see the other one. Please open. Is there another question? We come back to the cystic and also to other tumors, lesions of the pancreas, and you can give us your questions if you like. Please give the questions in the chat, and then in a break or after the presentation we come back to your question. Then we want to thank you, Zeno. We want to continue with your colleague that is Tudor Matkas, and he will give us a presentation about the paper you proposed for us. Welcome.
Hello, thank you very much. I'm going to share my presentation now. So, can you see my screen?
Not yet. Now.
Now, is it? Do you see the presentation now? Or not yet?
Yes, we see it, but it's not in presenter mode.
Put it in presented mode.
Like this? Is it all right?
Perfect.
Okay, so can I start?
Yes, please.
Okay, thank you. So, first of all, my name is Magda Tudor. I'm a student in the final year at the University of Medicine and Pharmacy in Cluj-Napoca, Romania. And today I'm going to present you a paper regarding the diagnostic accuracy of transabdominal ultrasound in chronic pancreatitis. So, first of all, I'm going to make a short presentation about chronic pancreatitis. I'm going to start it by defining it as a continuing inflammatory disease of the pancreas characterized by irreversible morphological changes that typically cause pain and/or permanent loss of function. Usually, chronic pancreatitis can be diagnosed using the Mayo score. Mayo score, which is both a clinical and an imagistical score. In the diagnostic criteria for chronic pancreatitis, there are 4 points that are required for the diagnosis. So we have the diagnosis when you have at least 4 points. We can get 4 points just from one criteria if that criteria is fulfilled by pancreatic calcifications or typical histological findings. The other criteria of high importance of 3 points in this case are moderate or marked morphological changes on CT or endoscopic ultrasound, or definite morphological changes on MRI. These type of changes, they need to be combined with another criteria, so you have at least 4 points. The other criteria include reduced exocrine pancreatic function, history of acute pancreatitis or upper abdominal pain, or diabetes mellitus. Going further and talking about ultrasonographic diagnosis of this disease, I'm going to firstly present you some images of ultrasound. So in the first image, there is a capture of transabdominal echography, in which you can see here written with C the calcification and the calculus, and on D it's a marked main pancreatic duct. In the image below this image, there is a picture of endoscopic ultrasound in the same patient, where you can also see here written with the C letter, the calculus or calcification, the main pancreatic duct, which is dilated, and with D you can see small dilated ducts. Then in the other image, it's transabdominal echography image, where can be seen also wrote with C. You can see the calculus, and you can see then the main pancreatic duct, where the walls of the main pancreatic duct are hyper-echogenic. In the image below that, you can also there can also be seen an hyper-echoic duct wall. You can see the double sign, and also you can see minor caliber variations. So we don't have a straight duct, and also you can see in the other part of the image the tissue stranding or lobulation, which is a detail which can be seen only in endoscopic ultrasonography usually. Then in the next images that we have, in the first one here on the right, on the left image, there can be seen the calcifications in the head and in the body of the pancreas, and you can also see the shadowing of the ultrasound. Then in the next image, there can be seen the calcification, here a calcification in the main pancreatic duct, and a dilated pancreatic duct here in the right. And also in the last image, the C image, there can be seen a chronic dilation and also caliber variations in the main pancreatic duct here in the body of the pancreas. So when a GI doctor is trying to diagnose chronic pancreatitis using endoscopic ultrasound, there is a criteria called Roseman Criteria, which also is a score that is using two main directions in the features. So this score contains both parenchymal features and ductal features. After using this score and using major and minor criteria, the score will have 4 different classes. One class, Roseman 1, means that the modifications that are seen are consistent with chronic pancreatitis. The second class reveals modifications suggestive to chronic pancreatitis. The third one, it's indeterminate for chronic pancreatitis, and Roseman 4 means a normal pancreas. From both parenchymal and ductal features, there are minor criteria and major criteria. Major criteria are important in this case because based on the combination of major and different minor criteria, we can address a patient in one of these classes. What's important for us to remember is that the major criteria from the parenchymal features means hyperechoic foci with shadowing, so echogenic structures of at least 2 millimeters in length and are wide enough to produce a shadow. And from the ductal features, the major A criteria is calculi to be seen in main pancreatic duct, which in the definition is echogenic structures with acoustic shadowing within the main pancreatic duct. From the other minor criteria, we have from the parenchymal features, we are having a score regarding lobularity without honeycombing or with honeycombing, different hyperechoic foci without shadowing, cysts and stranding, all of these can represent a minor criteria. And from the ductal features, we can have minor criteria as irregular MPD contour, dilated side branches, main pancreatic duct dilation, or hyperechoic main pancreatic duct margin. What's important for us to remember is that the diagnosis of chronic pancreatitis can be made having two major criteria, major A and the other major A and major B, or the different combinations between a major and few minor criteria would represent the different classes of this Roseman score. So this criteria was based on endoscopic ultrasonography. I'm going to discuss now a bit the limitations of ultrasonographic diagnostic methods in both transabdominal and endoscopic. So the limitations of transabdominal echography is, in first place, the long sound wave distance. Also the patient factors. Here in the patient factors, what is to be discussed is we can be thinking of a obese patient. We can be thinking of bowel gas. So these factors would impair the sound wave to cross up to the pancreas. And also transabdominal ultrasound usually has a lower resolution, a thing that we saw earlier in the images that I've presented you regarding the lobulations and minor details. Endoscopic US, on the other hand, has a better resolution, but also it has a steep learning curve. So for an examiner to be capable of making a high quality endoscopic ultrasound, it is required a lot of practice, a lot of training. Also, endoscopic US regarding the patient, it's an invasive method which produces lots of discomfort, and also there is a need for sedation. So after making this introduction of chronic pancreatitis and ultrasound in this disease, I'm going to present you a study. The aim of the study that I've presented you that I'm going to present you is to evaluate the diagnostic accuracy of features that are detected by a high-end transabdominal ultrasound scanner compared with the chronic pancreatitis diagnosis defined by diagnostic score combining clinical and imaging features, which is the Mayo score that I've presented to you in the beginning. Also, this study aimed for ultrasound findings to be evaluated according to the criteria from the Roseman consensus to address possible improvements in diagnosis accuracy. So this study, I'm going to talk to you a bit about the study design and the methods that were used in this study. So this was a prospective observational cohort study where the participants were referred for suspected chronic pancreatitis. So in the inclusion of the patients, they were initially eligible 141 patients. 7 of them were not included because they did not have a Mayo score above 4. So according to Mayo score, they were not candidates for chronic pancreatitis. After that, it was performed in all the remaining patients. They had a transabdominal echography performed. 10 of them were excluded because of poor sonographic condition, like bowel gas or fat deposits or obesity. So from the included patients, finally, it was just 124 patients to be taken part in the study, from which 54 of them were diagnosed with pancreatitis, and the other were not having the whole criteria for pancreatitis. The two groups that were separated in this one, so it was the pancreatitis group and the control group. Here are the demographics and the lab results for this for these patients. So statistical differences could be seen in those two groups regarding body mass index, including the status of a smoker, the alcohol consumption, the hemoglobin, the glycated hemoglobin, the level of fecal elastase, and duodenal bicarbonate. The results of this study, it showed mainly that the whole pancreas could be visualized in 61 of the patients. So in this visualization, we are talking about transabdominal ultrasound. So just 61% of the participants had their whole pancreas visualized. Sufficient visualization for inclusion was achieved in 92% of the participants. The pancreatic tail, though, it was poorly visualized, so just a quarter of the patients included in the study had their pancreatic tail examined by transabdominal approach, and in 10 patients, transabdominal US was inadequate, so they were excluded from the study. Also, this study tried to measure the agreement between ultrasound and CT scans. So regarding the calcifications, it was almost a perfect agreement, which meant that what could be seen in CT could be also visualized in ultrasonography in a great percentage. And also regarding the cysts, the agreement between ultrasound and CT scan was substantial. This study also aimed to compare, while doing the transabdominal ultrasound, this study was trying to compare the classical score that was used before or the Roseman score, which was currently used in endoscopic ultrasound. So in the imaging here, we have the ROC curves for these two ultrasound scoring systems. This was done for the patients that had a Mayo score of at least 4, and the cutoff for sonographic diagnosis of chronic pancreatitis was either a Roseman score of 1 or 2, or a classical score of above 3. The classical score included different morphological examination that could be seen in conventional ultrasonography. The ROC curve that was measuring the diagnosing accuracy of ultrasound have shown that they had a great sensitivity and specificity. So here are the results in this table. So accuracy of diagnosing chronic pancreatitis using an ultrasound classical score was great, and using a Roseman score was also greater, but the difference was not that high. The specificity was the same using the both scaling methods, but the sensitivity, it was lower in the classical score. So overall, the Roseman score is perhaps a better score or tool to use when trying to assess the pancreas with ultrasonography. Also, this study had interesting results in regarding exocrine function. So the patients that were diagnosed as having a chronic pancreatitis or Roseman scale 1 or Roseman 2 were put in a group, and the other patients that had a Roseman score of 3 or 4 were the second group. For all these patients, it was measured the exocrine function with the secretin stimulated endoscopic test and measuring the peak bicarbonate cutoff, which had the value in here of under 80 millimoles per liter. We had the division in 2 groups, and it was found that the difference based on the Roseman group, there could be told if the patient has or does not have an exocrine failure. So to be clear and trying to explain again, the most severe exocrine failure was seen in the patients with a Roseman score of 1 or 2. And also the prevalence of exocrine failure was higher in this group. So Roseman 1 usually meant a clear diagnosis of chronic pancreatitis, while Roseman 2 meant a probability of chronic pancreatitis, while Roseman 3 or 4 meant just minor modifications that could not be considered yet a chronic pancreatitis. So in the discussion of the study that I've tried to present to you, it has to be said that this was the first prospective study to assess the ultrasound accuracy in chronic pancreatitis. The main findings of the study were regarding that the pancreatic ultrasound has a good diagnostic accuracy in both scoring systems, in both classical and both Roseman system. The grade of exocrine failure was correlated to the severity of sonographic changes in the chronic pancreatitis group. Also, the agreement between transabdominal ultrasound and CT in the detections of both calcification and cysts was excellent, and that Another finding is that the differentiation between intra and extraduct locations of the calcification and the detection of minor feature such as stranding, minor duct dilations, and ductal hyperechogenicity are challenging in ultrasound, especially in transabdominal ultrasound. So comparing another studies that were done after this study, I'm going to present you now a study that compared the agreement between different scores and different diagnosing modalities. So this study found that in the diagnosis of chronic pancreatitis, comparing the CT classification results and ultrasound Roseman results, the agreement was moderate. The unweighted CT score and unweighted ultrasound score was moderate. Regarding the calcifications, the agreement was good and very good comparing the CT with the ultrasound, and a great agreement was found in comparing ultrasound and endoscopic ultrasound. And also in another study that compared the agreement between these methods, have found that regarding calcification, ultrasound and CT scan has a great agreement. And also here, it was calculated. It was called the intra-class correlator, where it was they were trying to correlate the accuracy of diagnosing a patient with chronic pancreatitis using transabdominal or endoscopic ultrasound. So agreement between these two ultrasound methods, it was really good in both unweighted criteria or in Roseman criteria. Also comparing the abdominal ultrasound and endoscopic ultrasound, a moderate to good correlation was found in identifying calcification, cysts, irregular MPD contour, and in finding main pancreatic duct dilation, while endoscopic ultrasound was definitely greater in identifying lobularity, stranding, dilated side branches, and also finding hyperechoic MPD margins. So concluding my presentation and the studies that I've tried to present to you is that ultrasound has a good diagnostic accuracy in this disease. The extent of sonographic changes is reflected by the grade of exocrine failure. Some minor features are difficult to visualize by the transabdominal approach, but if needed, they can be greatly seen in the endoscopic ultrasound approach. The adjustment of weighted scores to fit the performance of transabdominal US in practical diagnosis should be explored in future studies, meaning that these results that I've presented to you support the place of transabdominal ultrasound as a simple radiation-free and non-invasive first-line modality in the clinical workup of the patients with CP. So these studies highly recommend to use transabdominal, to also use transabdominal echography in the first steps of diagnosing chronic pancreatitis. This is my presentation. I wrote here the references. Thank you very much for your attention. And if there are any questions, I hope I'm able to answer them. Thank you very much.
Thank you very much, Tudor Mokdas from Cluj. It's open for discussion that the study and the presentation. Yes, thank you. David, have there been some questions in the chat?
Not up to now. No questions in the chat right now.
In the early presentation, there was a question about chronic pancreatitis and diabetes, and I would ask: are there specific signs? You have reported that we have in a higher level of chronic pancreatitis, we have more cases of exocrine insufficiency. Have we also signs for that it caused, they are specific for an endocrine insufficiency to produce an diabetes? Have we specific signs in transabdominal ultrasound. They are specific to that the patient more often will get in diabetes. Have you found that, Zeno or Christian? He is already there. Can you help us?
I think that in these studies, there was no comparison between groups of different diameter of the pancreatic parenchyma or the main pancreatic duct. My impression is that if we have an atrophy, a severe atrophy of the pancreatic tail and body parenchyma, exocrine and endocrine insufficiency are more likely, but I think there are no real data, no quantitative data. For me, the most important thing is that these three studies together show that we don't need CT for diagnosis of chronic pancreatitis, and it is very often used to diagnose this disease. I admit that there are some cases in which visualization of the pancreas may be 10%, as in this study, is not enough to have the diagnosis, but in all the other 90%, ultrasound is, in my opinion, and you have said this, the first line method to diagnose chronic pancreatitis, and also, and this was not a topic of the studies, to look for complications, for example, for splenic vein thrombosis and for stenosis of the bile duct.
Okay, I think the complications that are another thing. What is with the high frequency ultrasound transabdominal? That is in resolution. It's between transabdominal with a convex probe and the endoscopic ultrasound. Are the results then better with high frequency probes? And when we can use it?
Can you hear me?
Yeah.
One of the studies was actually done with that kind of transducers, and they got definitely better results than a normal abdominal probe, because we have higher frequency. It's the virtual convex probe, and now on several machines we have very good transducers designed for abdominal application, and so we are able to see the strength with a normal abdominal transducer. We are not able to see those changes, and to see sometimes if the patient is not fatty, but to see even dilation of the branch duct. But there are not very frequent situations when you are able to see. For calcification, yes, it's clearly an advantage, because we can differentiate the intracannular or extracannular location of them. So it will bring more, because there are in between a normal transabdominal examination and US, but it depends on the visibility of the pancreas and on the thickness of the abdominal fat. If you have a lot of fat, then it's very difficult to see the changes. But this picture is what we have now clearly demonstrate that with this kind of transducers, you see very well, you see the calcifications, and it's clearly an advantage. And starting with that paper, I try to use whenever it's possible those transducers to see more in chronic pancreatitis.
Okay, last question was by the friend from Cameroon about how visible is the pancreatic tail. In the study, it was reported that, and you also reported that the rate is lower. And what is in endoscopic ultrasound? How visible is the tail of the pancreas? It's better?
You should see the pancreatic tail in all cases if there is not an surgical altered anatomy, or if there is not a tumor of the stomach. But in in practical work, I think there will be also cases that small tumors of the pancreatic tail will be missed, maybe 10 millimeter tumor by endoscopic ultrasound. But if you always try to see the splenic vessels in the splenic hilum, then I think in all cases, the pancreatic tail should be visualized with endoscopic ultrasound. But there are no studies, for example, comparing endoscopic ultrasound to CT using fusion techniques also. But we have one Korean study comparing abdominal ultrasound and CT using MRI, I think, comparing the results, and they used the fusion technique, and they showed that in a surprising high percentage of cases, parts of the pancreatic tail were not visualized, despite the examiner said he had examined the whole pancreas. There are some areas which are difficult as a result of the study.
Okay, thank you very much. We come to the next, and Christian Jensen is already on start. You please begin with your to give us presentation of your cases.
Yeah. I start with one which I have not prepared for this webinar, but it is related to the question to the high frequency transducers. And this one was one case we presented 2 days ago at the United European Gastroenterology Week, which was virtual, and we had an ultrasound area totally virtual from Timisoara and from Strausberg, Germany. And one case was of chronic pancreatitis. And here you see a high frequency linear transducer in a case of an distal bile duct stenosis in chronic pancreatitis. I have only this short video, and you see this is a distal bile duct and this is pancreatic head. And you see as Stenosis, we can see dilated side branches. We can see very small stones of only, I think, 1 or 2 millimeters, which are inside the dilated ducts. And we can see that there's no tumor, only fibrosis. Here's the duodenum. That means in not obese patients, these high frequency transducers are very well used for diagnosis of pancreatic diseases. Now, I tried to upload my presentation for this afternoon. I have prepared 5 cases. I think the time will be not enough to show all of them, but we will try to have 2 or maybe 3 cases. The first is a real occurrence some years ago, and there was an ultrasound course for beginners, a 3 days course, and it was held in the western part of Germany. And I called this case a nightmare ultrasound course because there was a 31-year-old female physician, a young physician starting with ultrasound, and attended this course. And as in Germany usual, the participants examine each other. There are no patients, but they try to learn ultrasound, how to perform, and sometimes we have incidental findings. And each group of 5 persons was supervised by one experienced instructor. And in this case, I don't have a video, I think, or it is a video, yes. This young lady had this incidental finding: no pain, no previous imaging. And you see that there's a large, maybe 5 or 6 centimeter large cystic structure in the region of the pancreatic body, maybe in part of the tail. And of course, this seemed to be a serious finding, and therefore she was very much worried. And we performed some days later in another part of Germany, in Strausberg, this endoscopic ultrasound. And here we see again this cystic structure within the pancreatic tail and body. And you can see some features which are important. There's one septation. Alongside the septations, we find some mini cysts within the cyst. The content of this cyst is not completely anechoic, and at the base of the cyst, we can see such a solid structure of medium echogenicity. This is the hilum of the spleen, and that means the lesion was inside the left pancreas. And we saw, it was not to be seen in the video, also these droplets which are connected to this large septum. And here we can see the small, let's say, daughter cysts is not the correct word for the pathologist, but in imaging, small cyst within this large cystic tumor of the pancreatic body and tail. And now I would like to ask you for your diagnosis. And I have heard that two of our medical students from Brandenburg were able to bring these questions into a Mentimeter format. Am I right, David, that you now can present the question to our audience to vote?
Exactly. So I also prepared it, so I will have a look. You also have in the chat a link to menti.com. When you use this Menti link, you can also see my presentation with the question. So you can also go on the link in the chat, and then you have to see the presentation. So I will also... Herr Jensen, Sie müssen, glaube ich, einmal Ihre Präsentation beenden, damit ich meine machen kann.
Okay.
So.
It is now stopped.
Ja.
Okay.
Ist gut.
Aber das waren jetzt nicht die... Bisher habe ich gesehen, das waren die Mentimeter-Fragen, nicht die not the right questions of presentation, Professor Jensen.
Yeah, but I also have this one here. So, and then when you go with the link on Mentimeter, or you can also use your phone on menti.com, and then you can enter the code 5871 7865.
Kann ich nicht.
I think we can't start because nobody is within the Mentimeter platform now. Or have there anybody connected already?
I don't think so.
If not, we can do it in the other way, that I use my presentation and ask you, and you can answer in the chat, or you can open your microphone to answer. But it is...
There's
yes, one participant. Please take part, all the other. It is a little bit funny and better than only to use my presentation. If there's only one, there's no competition.
So we can also have a look if it's working.
No. Yeah, but we have to ask the question before. It was not to be seen. Okay. The answer from this one participant was this is a pseudocyst, and this is not right. But I will give you information why this is not the right answer. I hope you can see now my presentation again. Here we are. And Yes, I asked, is this a pancreatic pseudocyst or is this an intraductal papillary mucinous neoplasia? This is a tumor, a cystic tumor, which is arising from the pancreatic ducts. There are two types. One is arising from the side branches, and one is a cystic ectasia, a neoplastic ectasia of the main pancreatic duct. This is a well-known tumor of the pancreas, a mucinous cystic neoplasia, or better known with the term mucinous cystic adenoma, or is this a cyst adenocarcinoma? And the correct answer is the third one. This is indeed a mucinous cystic neoplasia, an adenoma. That means it has an potential to have a malignant development. And I show you now an endoscopic ultrasound contrast study. Now the contrast medium agent comes, and you can see that the septum as well as the small cysts, was better to be seen in the start of the film, have enhancement. That means contrast goes into the septae and into the walls of these small cysts, but very important, not into this solid part, which is here in this region. There's no enhancement, only enhancement here of the cysts inside. And I show you again. That means you can use this technique of contrast enhanced ultrasound not only with abdominal ultrasound, but also with endoscopic ultrasound. You can use also the high frequency transducer. Here is this solid tumor and there's no enhancement. And that means it is not really a tumor inside this cyst, not neoplastic solid tissue. This is mucin. This is maybe also debris, but in this case it is mucin. And because this is a mucinous neoplasia of the pancreas. And not to lose too much time, you can answer using your microphone. Do you think that what we have seen predicts a high risk of malignancy, or think of the 31 years old colleague, or is this a benign neoplasia, which of course has a risk to get malignant, but at this time there are no real criteria of malignancy, yes or no? And you can use also the chat for to answer this question. What is your opinion? I don't see answers in the chat. I don't hear anything. Okay, not to lose time, there are no criteria predicting a high risk of malignancy beside one, and this is the diameter of the lesion. There are two criteria which are predicting the risk, and one is the size of more than 4 centimeters, and this had 5 to 6 centimeters. And the second one are solid mural nodules or solid parts of this neoplasia, and we didn't see any, and used contrast enhancement. And this, what seemed to be a solid lesion within the mucinous cyst, this was only mucin. It seemed to be solid, but it was not vascularized. There was no enhancement with contrast medium. Therefore, only the size was the criterion. And here you see the operation situs of this patient. It was not possible to perform laparoscopy. And therefore, we can see an open abdomen with this large cyst. The surgeon should always try not to destroy the capsule of this tumor, because this can cause peritoneal mucinosis. This is a quasi-malignant disease for the patient. And the surgical pathology was a low-grade adenoma. And
Christian, there was one vote for yes by Mr. Allison.
Mr. Allison was Was right. Yes, he
Yeah,
was right.
thank you.
Because of the diameter. And now I would like to ask you a very important question. DIGUM is a German Society for Ultrasound in Medicine and Biology, our society in Germany for ultrasound practitioners. And now I ask you, it is dangerous to participate in a DIGUM ultrasound course, or it is life-saving, or it is exciting, or it is educative? Please answer using the chat. What is your opinion? More dangerous or more life-saving? Or would you like to participate in a German DIGUM ultrasound course because it is exciting and educative? The question is related that this young lady participated actively in this course of DIGUM and in this course got this important diagnosis. No answers. I think it is not dangerous because in this case, yes,
educative. Yes, was the answer.
Yeah. And Niels Storm says that please become a member of DIGUM. In this case, it is not dangerous. Okay, this is also a good answer. Yes, as I think it was really exciting because this is a rare case and it was life-saving for the patient because otherwise there was no chance to get this information and to be operated before malignancy occurs. Okay, these tumors always went into malignancy. And if you go to operation statistics, you have nearly 20% with invasive or in situ cancer in these large mucinous adenomas. Some are borderline and still have 70% as in our case only adenoma. And you can use for characterization of cystic tumors of the pancreas, transabdominal and endoscopic ultrasound, and especially contrast enhancement, because enhancement is an important criterion for neoplastic cysts. We saw the enhancement of the septae, but we didn't see enhancement of a nodule. These nodules are very predictive for malignancy. This is well known from a meta-analysis and several studies. And in this case, it helped us contrast-enhanced endoscopic ultrasound to characterize this cystic lesion. Because if you only have the B-mode image, as in our case, this is from literature, it is very difficult to say, is this a neoplastic nodule or is this a neoplastic nodule? And surprisingly, in this case, this is a neoplastic nodule, as you can see from histology, and this is only mucin, as in our case, and contrast-enhanced ultrasound can make the difference. I show you two examples. This is a nodule within a cyst. You inject contrast medium and there's no enhancement. And this means, again, this is only mucin and no neoplastic nodule, and therefore there's no indication for operation. And this is another case of a side branch, IPMN, another type of mucinous cystic neoplasia. And in this case, again, we perform contrast enhancement, and you can see here is enhancement in this nodule, and therefore this is neoplastic solid tissue. And this patient went to operation, and this was high-grade dysplasia inside a side branch IPMN. A useful technique, transabdominal and also endoscopic ultrasound. The name of my second case is At the Wrong Place. And let's look at this wrong place. This was a 42-year-old female, and she went to a very famous professor in Germany. He is famous for his beautiful ultrasound images and for being the first to perform contrast-enhanced ultrasound in Germany with a lot of success and with a lot of lectures, which was presented worldwide. And he made the examination of this young lady. I have I don't have the images from transabdominal ultrasound, but he found an hypervascular lesion inside the pancreatic tail. And this patient went to me and I performed endoscopic ultrasound. And here you can see this oval solid tumor within the pancreatic tail. This is pancreatic tail, this is the spleen, this is splenic vessel, and here you see this tumor. And you have several techniques. You have also for transabdominal ultrasound. I think Zeno mentioned some of them. One of them is elastography, and elastography is a technique to show differences in tissue elasticity. And we can learn from this elastography study that this tumor is well created but has the same stiffness or the same elasticity than the surrounding pancreatic parenchyma. Most of the malignant tumors are stiffer, of course, than the pancreatic parenchyma. And the second technique, you have learned already that we can use it also with endoscopic ultrasound, is contrast-enhanced ultrasound. And this was very impressive for me. It was the first case with this diagnosis I had ever seen. And you see that in the pancreas, there's some enhancement within vessels, but the longer we look, there's some hypoenhancement in the pancreas. It gets darker. The contrast agent washes out in the time of maybe 1 minute after injection. And the tumor has a lot of enhancement also after 40 seconds and after 1 minute and after 2 minutes. And this is a clue for diagnosis. And if you have heard something on other abdominal organs, then you may be able to give the answer. Have you any idea what this could be? Is this a cancer? Is this a pancreatic neuroendocrine tumor? Is this a small spleen within the pancreas? Or pancreatic adenocarcinoma, as already mentioned? Or is this a cyst adenoma, a microcystic type?
You have seen the answer of your colleague from Romania?
No. Oh,
okay.
Yeah,
Simona
okay.
Ianitescu.
Yeah, Simona, I know you. You are a specialist in splenic ultrasound, and of course, you should have the answer. And you are right, of course. This is accessory intrapancreatic spleen, because spleen is that organ in our abdominal cavity which has the longest enhancement with our SonoView, our ultrasound contrast agent, longer than hepatic tissue. It may be last for 5, 6, 7, up to 10 minutes. And this is unusual. And you have seen it now inside the pancreas. And we know that I think about 7% of all ectopic spleens, small nodules, are in the region of the pancreatic tail or inside the pancreatic tail, as in this case. And most people would say this is a pancreatic neuroendocrine tumor, because these neuroendocrine tumors also have a high uptake of our contrast agent, but not as long as in this case. Is another case, 1 minute. Here is this ectopic pancreas, 1.5 minutes, 3 minutes enhancement, and lower enhancement 4 minutes after injection. And you don't see any contrast agent in the pancreatic tail after 1 minute, only a little bit in the splenic vein. And here all is dark, but only this tumor takes up, has no washout. And this is because of the sinusoids within the splenic tissue. And of course, this influences management, because you don't need surgery, but you can perform. We did it because it was our first case. We can perform cytological diagnosis using endoscopic ultrasound, FNA, and of course, you can make a follow-up but it is not necessary if you have a clear diagnosis, as in this case, and therefore we performed endoscopic ultrasound guided fine needle aspiration, and you can see a lot of blood cells, lymphocytes, plasma cells. And if you give a special immunocytochemistry to this specimen, this is CD8, then you can see very good the internal anatomical pattern of the spleen, the sinusoids with its endothelia, and they stain for CD8, and this is proof of diagnosis. But meanwhile, we know that in all cases, these tumors in the pancreatic tail, we have like this. They have an enhancement which lasts longer than 3 minutes, and therefore now we don't need any fine needle aspirations, because this is the only tumor in the pancreas which this behavior, to my knowledge. Okay, have we time for a third case, or should we finish now?
I think if it is short, then we can use. We have 5 minutes.
Okay, then I try to show you a really short case at the moment. Not this is a more complex one. Case 5. I hope we have it in 10 seconds. Yes, this is the case. This was a patient with an acute pancreatitis. He was 82 years old, and you can see, you will know the anatomy because Professor Sparches has shown you. This is the aorta. Here you can see the celiac trunk, and this means that we are here in the region of the pancreatic body. This is pancreatic tail, and here, not well seen in this case, pancreatic head, and here we have the stomach. Here is fluid. And what is your diagnosis? Is this an acute pancreatitis with edema and effusion, or do you think that this is necrotizing pancreatitis? Have you criteria with transabdominal B-mode ultrasound? Please use the chat or open your microphone to answer. What is your opinion? Have we criteria with B-mode ultrasound to answer my question, or do we need another technique? Nobody answers in the chat. Okay, because we don't have so much time, I give you my answer. Of course, we have acute peripancreatic fluid collection within the lesser sac, and we have a inhomogeneous pancreatic parenchyma. It was hypoechoic, but we didn't see any solid tumor, but we saw a small cyst. I show you again the video file. Here's a small cyst. It turned out to be a mucinous cyst, later intraductal papillary mucinous tumor of the pancreas. Here is the fluid in the lesser sac, and here's the inhomogeneous hypoechoic pancreatic body and tail. These are the findings. And diagnosis, I asked if this is pancreatitis with edema and fluid collection, or it is a necrotizing pancreatitis. You can't answer this question only with B-mode, and you should use always a contrast-enhanced technique. And if you can see the pancreas so very well as in this case, you should use a contrast-enhanced ultrasound. And you can see, and this was surprising for me in this case, that 2/3 of the pancreas, pancreatic body and pancreatic tail, has no uptake, no parenchymal uptake of contrast agent. You see only some in the pancreatic parenchyma, and in the pancreatic cut, there is enhancement. That means enhanced ultrasound in case of acute pancreatitis helps us to establish a diagnosis of acute necrotizing pancreatitis. And there are studies which are showing that there's a very good correlation between a CT diagnosis of necrotizing pancreatitis and the contrast-enhanced ultrasound diagnosis. Both indices, the Balthasar index from CT and the contrast-enhanced severity index, have a very good correlation, and there's also a good correlation with the Rensen score, which is sometimes used at intensive care units to characterize the severity of pancreatitis. And this have been my 3 cases, and I ask you to do ultrasound always with love. Thank you.
Okay, thank you very much, Professor Jensen and David or Niels. We come now to the next step. I think, please show us the question. But before you start with Mentimeter, you have to give the participants a chance again to come into the Mentimeter platform. We want to try it again, please. Oh, that's good. That is helpful, I think.
Yeah, please join us at Mentimeter. You have 2 options. One is the QR code you're seeing, and the other one is the code on the top of the screen. Just go to menti.com and use the code so you can take part in the quiz. In a short quiz, the time has progressed. Niels, please upload the presentation.
Okay, perfect. So I will share my screen here.
Or should we give you 1 minute, please? Participants, please answer us. Do you need a minute with the QR code? We don't want to take it away, so you can't participate.
And you can also see the code on the Mentimeter slides. When we also open it, you see it also on the head base. Okay, perfect. Okay, David, you have to stop your sharing.
Yep.
And I can share my screen. Okay, good. Yeah, so welcome to the WFUMB students webinar with our ultrasound quiz. And because of the time, we will also skip some questions and also want to go to our ultrasound quiz. So the first one is a little bit a standard question. So we have the question, what ultrasound plane is shown in the next picture? So we have here an ultrasound video, a loop from it.
Some beginner question.
Okay, then we go to the questions. Is it working?
No.
No, you see, just restart. I closed my presentation. Maybe that's conflicting. Sorry.
Looks better. Perfect. Okay, so we will have 5 participants. Then we can go to the question. Is it a transversal plane? Is it a sagittal plane? Or is it a right upper quadrant view? What do you think? You also have 7 seconds to answer.
Time's up.
Yeah, exactly.
Yeah.
All 6 are right. It was a transversal plane. Okay, perfect. A good start. So the next question is the transverse extent of the normal pancreas. Here is the question: how long do you think is it? So we also have the picture here, the transverse picture of the pancreas. Then we go through to the question. So is it more than around about 45 centimeter, 12 to 15 centimeter, or is it a little bit bigger, so around about 20 to 25 centimeter? Also have 5 seconds. Yeah, the most were also right. It's around about 12 to 15 centimeter in the transverse extent. So it's called a normal pancreas. Perfect. Okay. David, the next one, would you like?
Sure. Yeah. Next, please. The video is coming up, and what pathology you can see in the picture. It's a short video. I think we should keep it up there a minute or 30 seconds so everybody can look closely at the picture. All right, I think we can proceed now. You have these possibilities. Three, two, one. Let's see. Which is right. Yeah, most of you are right. Professor Neumann, do you want to elaborate, or should we just proceed?
Sorry, I can't see. I can't give a comment because I can't see the screen.
Ah, okay.
That's a problem of connection, but I can follow only the Mentimeter on my iPhone in the moment.
Okay, the time has also progressed. So
we need to. You can continue 1 or 2 cases. You can do that. We have some minutes, but I can't give a comment. The comment is now I see I saw 1 moment, and you have to give an explanation what you see on the video a little bit. Yes, that's not necessary, I think.
So
yes,
the other one.
You can see there the head of the pancreas, and there are shadows and calcifications that are echo complexes in the head of the pancreas. Yes, that you can see there. And that is very typical. You heard about the signs of chronic pancreatitis, calcifications in the parenchyma of the head of the pancreas. We can continue now.
Okay, the next case. So we're looking for a lesion in the tail. These are 2 videos, so maybe 10 seconds for this one and 10 seconds for the other one, so everybody can have a look.
Yes, that is a round, nearly round lesion in the tail. It's free, nearly free of echoes.
the fourth question. Please look at your smartphone. The possibilities coming up. Is it a solid tumor, a benign cystic tumor, a pancreatic pseudocyst, or a gastric wall cyst? Please choose the answer. And let's have a look. The right answer was the benign cystic tumor. And what 3 people also are the pancreatic pseudocyst. How can we differentiate between these two, Professor Nürnberg?
I think the border was not very regular. It was a little bit irregular there. And in that situation, the differential diagnosis could be that it is an pseudocyst, but in the anamnesis, there was no pain, no history of pancreatitis, and no other signs of pancreatitis.
Okay, let's continue. Also a pathology again. Let's have a look. Also 2 videos again.
That is very similar to the case what Professor Jensen presented already. We have a contrast media examination of a cystic tumor with structures inside, with septae. It's a large tumor of diameter 8 centimeters. You can see it here in the native B mode with the structures, small cyst inside and others, but no nodules. And no clinic before, only you could, because it was really a little bit large, the palpation was possible.
So again, the possibilities to answer. "15 seconds left. Oh, a diverse answer. More than 1 or 2 options were chosen.
Yeah, remember the case, what was already presented. We have no signs of malignancy in a cystic tumor. And that means it's not solid because we have a lot of fluid inside. That means it's not a solid tumor. And it's inside of the pancreas. That means we have a benign cystic tumor, but there was an indication of operation because the septation and the cystic lesions inside, that means that we have a higher risk of malignancy in the future, in the follow-up. That's why. And because of the size, more than 4 centimeters, that was the other thing. That's why it's an indication for an operation, but it was a mucinous tumor, cystic tumor of the pancreas.
So the first leaderboard. Let's have a look who's the champion, or the name is good choice for the one who's now the one at the first place at the moment, and the hustler is the second one. So let us see if the champion can hold this position until the end. So let's continue. A close call between these two.
So we have also a pathology here in the next picture. So we will have a look what we can see here. And this is our next case. So you can also see a solid area here.
It's not the whole lesion is solid. We have a sedation. Yes, there's the dorsal part is looks like solid structure, but it's round, and we have also a duct of the pancreas is dilated. You can see it on the left side in direction to the tail. The Versungianus is, we can see the dilatation there. We have
So
one part, it's one part, nearly 1/3 is complete echo-free.
Then we go to the question here. So we have 5 different options. Is it an aortic aneurysm, large pancreatic carcinoma? Is it also a benign cystic tumor in an infected pancreatic pseudocyst? Or maybe is it a pseudoaneurysm? And the most ones said, or all said, it's an infected pancreatic pseudocyst, and that's totally correct. Perfect. So then we will also have a look on the leadership. We have also one case here.
Yeah, you can see an irregular and inhomogeneous pancreas, and it's a transversal section, what you see here, and you can't see the duct. And remember the one of the cases presented by Professor Jensen, and
okay, so we
have an obstruction of the stomach. There's a lot of fluid in the stomach. You saw that in the last video.
So your connection is stable. We're not hearing you.
Yeah, and the most were also right. It's an acute pancreatitis, which you can also see the irregular form of the pancreas. That's totally fine. Perfect.